This is a two-part video on monitoring of tissue perfusion in our patients suffering from shock. Coming to the definition of shock, the shock is a state in which profound and widespread reduction of effective tissue perfusion leads first to reversible and then, if prolonged, to irreversible cellular injury. The most important word here is the effective tissue perfusion. So what is required to have an effective tissue perfusion? First, we need a good macro hemodynamic, that is a good cardiac output to meet the requirement of the body and a good oxygen content in our blood. Despite having a good macrodynamic parameters, we can still have shock-like situations when our microcirculatory flow is compromised. Sometimes our macrocirculatory and microcirculatory flow is normal, however our tissue is still dysoxic because of abnormalities at subcellular level, which hampers the mitochondria's ability to utilize this oxygen for normal aerobic respiration. Now let us understand how we capture the oxygen from our surroundings and send it down to our tissue levels for utilization. So the normal room air oxygen contains around 160 millimeter mercury partial pressure of oxygen. So when we breathe in this air, we eventually established an alveolar partial pressure of oxygen of around 100 millimeter mercury. How do we calculate that? We calculate this as per the alveolar gas equation that I have mentioned here. The oxygen that is in our alveoli crosses through the alveolar capillary membrane into our blood. So once it does that, majority of the oxygen that cross over through the alveolar capillary membrane binds to the heme molecules in our RBCs. So as we know, one heme molecule can bind to up to 4 molecules of oxygen, and when all the heme molecules in our blood have bound to 4 molecules of oxygen, we say our blood is 100% saturated. The oxygen carrying capacity of hemoglobin is around 1.38 milliliter of oxygen per gram of hemoglobin at 100% saturation. Therefore, in order to calculate what is the amount of oxygen that is being transported in our blood bound to hemoglobin, we have to multiply 1.38 times the hemoglobin concentration in the blood times the saturation. So for a normal individual with an average hemoglobin of 15 gram per deciliter, this roughly comes down to 20 milliliter of oxygen per deciliter of blood. That is the content of oxygen in our blood which is bound to hemoglobin. A very minuscule amount of oxygen is also transported in the dissolved state. So whenever a gas is dissolved in a liquid, it exerts a pressure which is proportional to the content of the gas, and this proportionality constant is the solubility coefficient of the gas. For oxygen, the solubility coefficient is 0.003. Therefore, for a partial pressure of oxygen of 100 millimeter mercury, we are eventually having only 0.3 milliliter of oxygen dissolved per deciliter of blood, which is insignificant compared to the 20 milliliter per deciliter of oxygen which is bound to hemoglobin. Therefore, for all practical purposes, while calculating the oxygen content, we can ignore the dissolved oxygen fraction. The oxygen binding of hemoglobin follows a sigmoid shaped dissociation curve that we can get if we plot the PaO2 in the x-axis with the hemoglobin saturation in the y-axis. The curve has a sigmoid shape, and the reason is a very unique character of our heme molecules. So as we know, one heme molecule has 4 oxygen binding sites. So initially, when all the sites are free, the affinity of oxygen is not that much. But when oxygen starts binding to one binding unit, it induces some conformational changes in the heme molecule that increases the affinity of the heme molecule to the subsequent oxygen binding, Therefore, the initially somewhat flat slope becomes steeper with increasing affinity of hemoglobin, and this can continue till the hemoglobin is getting 100% saturated, at which the plateau is reached, where further increase in PaO2 will not increase the hemoglobin oxygen carriage. We can see that oxygen is transported across a pressure gradient from 160 millimeter mercury in our atmospheric air till around 100 millimeter mercury at the level of our alveoli to 1 to 25 millimeter mercury at the level of tissue, and this is what we know as oxygen cascade. If we want to calculate the delivery of oxygen per minute to our tissues, we have to multiply our oxygen content with our cardiac output. So, for a normal average individual, the oxygen content, as we know, is around 20 milliliter per deciliter, and the cardiac output is 5 liter per minute, which is 50 deciliter per minute. Therefore, the delivery of oxygen is around 50 into 20, that is 1000 milliliter per minute, out of which the normal resting oxygen consumption is roughly around 250 milliliter per minute. So, therefore, only 25% of oxygen is extracted by the tissues, and rest of the 75% is transported back to the pulmonary circulation. This graph explains the relation between the oxygen delivery and consumption. So, when in the initial part of the shock, when the delivery of oxygen comes down, the oxygen consumption is not affected, and therefore the markers of anaerobic metabolism is not increasing in the blood, that is, lactate levels do not rise. During this period, two things happen. One is the body tries to augment the oxygen delivery by increasing heart rate and thereby increasing the cardiac output, and second is that the cells are extracting more oxygen from whatever is getting delivered. Therefore, in a normal state, when 1000 ml per minute of oxygen was getting delivered, tissue was taking 250 ml per minute of oxygen. Therefore, the extraction was only 25%. Now, if something happens and the oxygen delivery has come down to 500 ml, the oxygen consumption still remains the same, around 250 ml per minute. Therefore, the extraction ratio, which is nothing but the ratio of the oxygen consumption and delivery, is increased to 50%. So, at this stage, really only the oxygen extraction ratio increases. Even without a decrease in the oxygen delivery, our tissues can still be anoxic if there is an alteration in the microcirculatory flow. So, what is microcirculation? Microcirculation includes the arterioles, capillaries and the venules with diameter less than 100 micrometer. This is the seat of transfer of oxygen and carbon dioxide and essential nutrients between blood and tissue. So, the microcirculatory dysfunction happens when the flow becomes stagnant, there is increased heterogeneity in the perfusion of tissue, and when the percentage of perfused vessels come down. So, this together is what we know as microcirculatory dysfunction. So, despite having a normal macrohemodynamic parameters, our cells can still suffer from dysoxia due to microcirculatory dysfunction, which we often encounter in septic shock patients, and we call this phenomena as incoherence between macro and microhemodynamic parameters. In the subsequent part of the video, we will explore the markers of tissue perfusion that we use in our clinical settings to diagnose inadequacy of oxygen delivery.